Dr. Marina Bowe, who's going to talk to us about making recovery a reality. Thanks, Marina. We'll get your you're up here in the blue.
Thank you, Catherine. It's fantastic actually to see this crowd here today, and hopefully as I speak you'll appreciate why I'm so happy to see the room so full. I was asked to speak about making recovery a reality, and I suppose the bigger question is, whose reality are we talking about? And I would like us all, as I speak, to think about what your reality is when you think about recovery. So I'm a consultant psychiatrist, so my reality is going to be my opinion as a consultant psychiatrist working in a recovery way, I hope. When I think about recovery, I always look back to Anthony's definition. This is the most widely quoted definition of recovery in the literature. It is always worth your while to take another look at it, because it talks about recovery being deeply personal and unique to the person experiencing mental health problems. It is a way of living a satisfying and hopeful life, even beyond the limitations caused by illness. Recovery involves developing new meaning and purpose in one's life. As one grows beyond the catastrophic effects of mental illness, and as a psychiatrist, my reality is to see those catastrophic effects at first hand, but I am only a bystander. I am not the person who is having the lived experience, and I think it's really important for mental health professionals to think about that when they're working with people. My training is in clinical recovery. I think about outcomes, symptom remission, cure. I look at what I see. So if I'm seeing someone who is depressed, my training is to ask, are you sleeping? Are you eating? Do you get enjoyment out of life? Do you feel life is worth living? But you know, as the experts by experience will know, that's only half the story. Because if I only ask those questions, I can completely miss the point. What is their life beyond their illness like? How have people recovered from the impact of their illness? This is a personal recovery, and maybe another term, a social recovery. It is rated by the person who is using the service. In a way, the way to work is in partnership, to look at a clinical and a personal recovery together. We haven't been so good at doing that, and perhaps that is why I am so delighted to see a packed room full of people with different recovery experiences here today. For a clinician or a mental health professional, what does recovery mean in practice? How do I do that as part of my daily work? How does it become core business? I need to think about hope. The people coming to see me need to be hopeful. That's the first thing you have to look for recovery. The hope that life can be better. But you know, I don't necessarily have the expertise in delivering hope. But someone with lived experience working alongside me in a team would be an invaluable asset, because that would be evidence, that would be hope. I have to look at asking people to take control of their own mental health. I don't fix people, I don't recover people. They recover themselves. If I believe I do it, I am somewhat deluded and need more education. I need to think about connecting people outwards from mental health services. What's the local GAA club? What goes on in the local library? What goes on in the local church? And you know what? Me and my team need to find time to do that. Because if we're not doing that, we're only delivering 50% clinical recovery. How do you do that? You work in collaboration with the people you serve. Not the people using your service, the people you serve. You're employed in service. Care planning. Clinicians are fabulous at care planning. We talk about goals, nice goals, social integration. But goals are roles. Should social integration not look at being reconnected to the local GAA club, being a member of the club, being a volunteer in the club, being a supporter in the club? That is a far better role. Everybody has a family. We talk about re-engagement with family. Everybody is a son, a daughter, perhaps a partner, perhaps a parent. That's a role. Reconnect people to those roles. Think about it. Mental health professionals, in my opinion, must have training in psychosocial interventions available to them in their local areas. They have to know what the landscape looks like. They have to know what's out there. That is why days like this are fabulous, because you can walk around and look at the various initiatives across your areas. But clinicians working in a recovery-orientated way in isolation is useless. One has to have commitment at an organisational level. And I think there can be no doubting the commitment of CHO 1 and 2, judging by the turnout here today. Commitment involves management looking at educating staff in services, releasing staff to attend recovery education, allowing and facilitating the attendance of the people with experts who are experts by experience in mental health. So one must facilitate service users and family members to partake and co-produce education. And you know, that involves payment, looking after expenses, and making sure their needs are facilitated in the same way as you would facilitate the needs of your staff. I've drawn attention here to a concept, recovery is for all. I have often had it said to me that recovery belongs to general adult psychiatry and isn't something one could apply to old age, intellectual disability, forensics. I have worked across a number of those settings, and recovery is equally valuable in those settings. And I would draw people's attention to a document on the Royal College of Psychiatrists' websites entitled Recovery is for All. Because if we look at what recovery is, achieving a life beyond illness, that is applicable to everybody. You're here today as part of ARI. ARI is modelled on IMROC methodology. IMROC stands for Implementing Recovery Through Organisational Change, recognising that the culture and the day-to-day business of an organisation has to change for recovery to be successful. IMROC involves looking at 10 key challenges. The first is definitely the hardest, even though it sounds quite simple. Change the nature of the day-to-day interaction with the mental health service. So as we think about that one, think about packed waiting rooms in dreary buildings and people waiting to be seen. Where's the hope in that? We need to look at individualised services. As you move through the IMROC challenges, look at things like changing the culture of risk. Look at things like developing co-produced education. Look at things like changing the workforce. Look at things like employing peer support workers and family support workers in your organisation. There are some specific recovery-focused interventions in mental health, and I'm just going to draw your attention to two of them: Housing First and Individual Placement Support, which deals with employment. Traditionally, in mental health services, we stepped people around housing. You went from high support to medium support to low support to independent living. that was my training. I knew no better until I came across the Housing First methodology, which says that people are placed in independent living first with the supports they need, and then you help them with their mental health or their addiction or whatever the problem is. There is a huge evidence base behind Housing First, and I'll talk about it in another minute. IPS is a similar model looking at employment. Traditionally, we looked at training and placing. IPS asks us to place people in employment with support. Peer support workers, I hope, are familiar to everybody. That would be a person with lived experience, embedded, working within the mental health service as part of the staff. Recovery colleges, another intervention that organisations can support. The development of education facilities separate to mental health services, where members of the community, members using the mental health services, and mental health service staff come together to promote and produce education on mental health. And there are a number of experts in the area of recovery colleges in the room today. If you are interested, please seek them out. Where's the evidence? Doctors love evidence. Well, here's some for you, and this is limited. Recovery-orientated practice is associated with successful discharge from inpatient units. This piece of research was produced by Professor Helen Gillespie, King's Hospital in London. Peer support workers are associated with a reduction in the length of hospital admissions and earlier discharge. Isn't that what we all should be aiming for? The evidence around IPS. There's an excellent report from the Schizophrenia Commission, Rethink Mental Illness in the UK, looking at this. The London School of Economics produced the evidence behind it. In the UK, 5 to 15% of people with schizophrenia are in employment. Imagine the cost to the economy of the people who aren't working. Using an IPS model, these rates improve to 60%. The second piece there covers the housing and Housing First. It's a piece of research from the Mental Health Commission in Canada looking at the implementation of Housing First in Montreal. Using a Housing First modality, 72% of people in the Housing First group achieved sustainable, successful, independent living, versus 29% of people in the treatment as usual group. The 29% of people, or the people who were unsuccessful in the treatment as usual group, had massive costs in terms of hospitalizations, shelters and emergency accommodation. So there is hard evidence behind recovery. There's also a different kind of evidence behind recovery. The kind of evidence I talk about is the successful human stories that you can hear every day from people with lived experience. And why is that not as important as a double-blind trial? And we need to start highlighting that. So for someone like me, who actually was involved with ARI at the start and remembers having 20 people in a room, it's a great feeling to stand here today and to say, recovery, finally coming to a service near you. But, you know, recovery values are not new. If you look back to the York Retreat, 1796, Highfield Hospital, 1825, these were founded against the backdrop of the big asylums with cruel and inhumane treatments. These hospitals were set up to look at what they called at the time moral treatment: respect, collaboration, social inclusion. 181 years later, and perhaps we were slow adapters in mental health, we have Vision for Change. And I think it's always worth revisiting the opening chapters in Vision for Change, because they talk to recovery better than I can. Recovery can be seen peppered through international mental health policy from the late 90s onwards. My own professional body have a group, Refocus, which is a group of psychiatrists, service users and family members co-producing education for trainee psychiatrists. Refocus is around since 2011. But I guess the joy today is recovery, an idea whose time has come, because we sit here and Michael is going to talk to the National Recovery Framework. ARI has grown to a room that has over 200 people in it in one part of the country. And I am told there was 300 at the conference in Kilkenny. Nationally, we have the Office of Service User and Family Engagement. Sometimes I have to pinch myself because it just doesn't seem like too long ago when all of this seemed like a dream. So the things I'm putting out there for you to think about for the day, because these are the common discussion points that are put to me as a clinician. Recovery is poor on risk management. I hear that all the time. It's dangerous. We can't practice in that way. What are you talking about? Well, recovery deals with focusing on people's strengths and promoting positive risk management. Now, if we want to think about restrictive practices and the benefits of restrictive practices as opposed to positive risk management, let's look at the building we're sitting in. Do we want to reopen it as a psychiatric hospital? Because that's what not practicing recovery looks like. Recovery is about carer burden? Actually, no. Recovery is about empowering people to be less dependent on their family members and significant others. My favourite one, because it's the one I believed, is, why are you talking to me about recovery? I'm a doctor. I'm doing it already. And I do remember my good friend, a social worker, saying, no, I want to talk to you about recovery, and being highly, highly indignant. That was in 2010. Thankfully, I've learned a bit, I hope, but I still have a distance to go. None of us are doing it already. And as clinicians, we're thinking about clinical recovery, and we need to think about personal recovery. Recovery is not anti-psychiatry, but it is a different way of working. It's about serving the people you're working with, hearing what they're saying. You may not always like it, and sometimes it's very hard for me when someone says, thank you very much, doctor, I don't want to see you anymore. But if I've empowered them to make that decision, I must respect it, because that's what recovery is about. If they have capacity to make that decision, I just got to live with it. That's my problem. There's no evidence. I hope I've addressed that, and I am here for the day, and I'm happy to talk further on the evidence base. The cardinal sin is to think you know it all and to forget to co-produce. So I have had Michael Ryan have a quick look at these slides in advance. To conclude, you've heard my recovery reality, but please, please, I am a clinician. You're seeing it through my eyes. What I'm really interested in is, what are your eyes? And I know we have people from all walks of mental health services here today. People with lived experience, family members, community groups, and managers. So please, think about what your reality is. And perhaps as we move through the day and you attend the workshops, how do we all collectively work together to make recovery a reality? Thank you.